Yeah, thanks kind introduction. It's my great pleasure to have opportunity to give a presentation in this meeting. I think it's very difficult task to cover 3 procedure within 15 minutes. So here's my disclosure. Let me start with the PFO closure. I think it's already shown in the ICE guide. The PFO closure is by Dr. An. It's very straightforward procedure, but more important thing is to identify the optimal patient. So Pascal classification recently suggested to find out optimal patient for the PFO closure. As you can see here, probable and possible usually recommend PFO closure. However, in unlikely population, usually recommend medical therapy because there is no benefit but increased risk of atrial fibrillation. So I would like to share 2 cases for the PF closure. First one is a septal aneurysm. 37 years female. She experienced a stroke and Pascal score is probable. So it's some good indication for the PF closure. But another issue is a very floppy septum. So aneurysm change. So I think that this is another some challenge for the PF closure. So several hospitals suggest different strategy for this patient from surgery and PF closure, percutaneously and medical therapy. So in this case, we did a balloon interrogation test. So balloon sizing is 15 millimeter. So this is not a good indication to apply usual conventional 25 millimeter PFO device, which is quite higher chance or higher risk of the embolization. So in this case, we use a 30 millimeter gold device. At the time, a gold device was available, but it's now not available. So we usually use another some 30 millimeter device. So patient has been uneventful for years follow. And the other case is small and long tunnel PFO, 52 years male. He experienced several times stroke, and previous hospital did lots of study, especially TE shows a PFO was definite, bubble was shown in LA, more than 20 bubbles. So this patient has a Pascal score of this patient was possible. Then we started with PFO closure with ICE guidance, as you can see, but it failed to pass the PFO. Then we check again PFO anatomy with a TE in our hospital. This patient had a long tunnel and very small diameter of tunnel and no atrial septal aneurysm and no resting shunt. So we decided to just continue medical therapy and then check another possible paradoxical embolism, so such as AVF, but there's no evidence of pulmonary AVF, and we applied the implantable loop recorder in this patient. Patient discharged, but patient experienced another symptom after 2 weeks. Then we did the MRI test, and MRI shows another region in brain, different location. So neurologists recommend the PFO closure. Then we tried to perform the PFO closure with a conventional method under guidance of TE, but it failed, so we changed it to the atherosis. Then it failed, and finally we decided to puncture atrial septum just adjacent to the PFO. Then we puncture, and at first we applied 25 millimeter device, but it not fully covered by for the PFO tunnel. So we changed the 30 millimeter PFO device, and we just covered whole PFO tunnel in this patient, and patient uneventful for 5 years. So here's my personal suggestion, especially technical aspect to PFO closure. If PFO3 is not clear, we should check another source of paradoxical embolism, such as a pulmonary AVF. And if size of PFO suspicious, balloon sizing would be helpful. And I would suggest to usually use the 6-branch multipurpose catheter, which is more talkable and backup support than 5-branch. If it do not work, change atherosis to get a more strong backup support. If it do not work, and I usually try to acetylene sheath and bronchobone needle to puncture the septum, which is a very somewhat special situation. Let's move on to the ASD. ASD is also very straightforward procedure. I usually balloon interrogation, check the sizing of the ASD with a balloon and TE, and both measurement, based on both measurement, I usually choose the optimal size of device. So here is a usual process under guidance of the APCIS. This case is we implant a fibula 24 millimeter device, but sometimes we encounter this kinds of patient. This is off-axis ASD, as you can see here. It's not so easy to cut on the limb of ASD, so we try to, in this case, balloon assist technique. So it's more make like axis of the ASD and decrease size of the ASD. So it is much easier to apply the optimal size of device, 24 millimeter. But otherwise, I think in this case, most of intervention is try to increase the size of device. So that is not a good option. And the other one is a multiple ASD. In case of multiple ASD, are close each other with the intervened tissue smaller than 5 to 7 millimeter, then we can cover only one device. However, it's more than 7 millimeter away, practically more than 6 millimeter, then we should check the size of the satellite ASD. So in this case, less than 3 to 4 millimeter, then we just ignore because this is not significantly relevant. So clinically relevant, but satellite defect is more than 4 millimeter, then we can close with a multiple device. So here's one of the example. There's a two defect here, and this defect is one of anterior superior and the other was anterior inferior. So we try to interrogate two hole, but as you know, sometimes it's very easy to pass through the larger hole, especially anterior, located ASD hole. So we just pass through the conventional catheter and just a balloon inflation. Then we try to attack to the another hole, smaller one. But in this case, fortunately, we were available echo navigation system. So just annotate marker here, then easily pass through this way. Then we check the sizing. Larger one for 13 and smaller one 4 millimeter, as already mentioned. So 4 millimeter is significant clinically relevant, so irrelevant. So we just close larger one with a fibula flex 2 for 15 millimeter device, as you can see here. Even though there is some residual jag, we just finish the procedure in this case. And the last one is very somewhat interesting case. 73 years male, large ASD with heart failure, atrial fibrillation. Then RVSP is around 60 millimeter mercury. So this patient, there is some possibility of the heart failure when we close the ASD device. So ASD size is 24 and 15 millimeter. Then we did the balloon occlusion testing, then LV-EDP significantly increased 20 to 36. So in this case, we applied a penetrate ampullature septal occluder 22 millimeter device. Then interestingly, LV-EDP is quite same, even after closure of the ASD. But another issue was occur in patient felt some palpitation and chest X-ray on the next day of the procedure. As you can see here, this is a weird location in the device was located in some weird location. There is some suspicion of the device embolization. So this device was in LV. So we did fortunately, device snare and removed the migrate device. But in this case, we have some caution because sometimes there is some possibility to entangle to the coda of the mitral valve. So this is another issue. So fortunately, we removed the device, and then we just implanted a 24 millimeter device. So what happened? As you can see here, even after the device implantation, there is some leak here. So even after balloon occlusion testing in this situation, LVEDP was increased. But after AS device implantation, LVEDP is somewhat slightly increased, 15 to 18. And patient was no symptom of heart failure, and with some maximal medical therapy, and RVSP is significantly decreased, 46, and chest X-rays was improved. So this is another possible message for this kinds of patient. So last part is left appendage occlusion. Left appendage occlusion recommendation is recently elevated, class 2A indication in patient with a long-term anticoagulation contraindicated. So currently available device is Watchman, Armlet, and Lambre is already mentioned by Dr. Zhou. One of the interesting is implanted success rate is approaching 100%, and safety issue, side effect is 0.5%. Then means a quite efficient and very safe device for the left appendage occlusion with the current device. So 80 years male, the indication of recurrent stroke during anticoagulation, but this patient issue is appendage size very large. Landing zone is 33 millimeter. So based on this TE measurement, we should choose an oversized device based on this measurement. And the CT landing zone is 36 and 38 millimeter. But there is no available conventional size of device, even Lambre or other Watchman or Armlet device. So this case is we ask to the company to customize larger device and septal puncture. Then here's a Lambre device, 42 by 44 millimeter device. This is, I think, the largest one in the world to implant the appendage until now. So it's quite successful and based with a heart navigation system. Then here's the final result is complete closed, the very large left appendage with this customized device. The other case is also indication of appendage closure is recurrent growth during anticoagulation, but as you can see here, this patient had a scoliosis. So that means most of structure and vessel or some heart structure were deformed. So here's a CT finding, and fortunately in this case we applied with heart navigation, so this is quite helpful to check the septal puncture site and location of appendage, as you can see here. But issue is the optimal imaging by TE could not obtain in this situation. So we usually perform the whole procedure under guidance of fluoroscopy in this case, and then follow result also checked by CT. So finally, in this case, we did a successful LAA occlusion with the Lambre 26 and 38 millimeter device. So in summary of my presentation, I think a more important thing is to ensure appropriate indication, and we should understand anatomy, especially complex intervention, and use optimal technique. And finally, we should prepare for the complication. Thanks for your attention.